Hello and welcome back to the conference. I would now like to introduce our first session of the day. It's regarding data linkage and knowledge sharing to deepen our understanding of child death. This session showcases projects where agencies have shared knowledge, information and linked data to support case analyses and improve understanding of the causes and risk factors in child deaths. Our first speakers for this session are Dr Rebecca Shipstone from the QFCC and Dr Paula Lister from the Children's Health Queensland, who will be presenting on the Paediatric Sepsis Project and the value of linked data and interprofessional partnerships. So I'll now pass over to Rebecca and Paula. Thank you.
Thank you so much, Jamie. Good morning, everyone. Today we would like to share with you...
Just waiting for Beck to join us.
I'm here. Can you not hear me? Can you hear me?
Yes.
Excellent. Okay, sorry. Good morning. Today we would like to share with you some of our recent work around paediatric sepsis mortality. And in particular...
We're co-presenting. Is Beck joining us?
I am. I'm here. Yep. And in particular, this presentation will focus on the value of linked data and interagency partnerships in increasing both the identification and understanding of child deaths due to sepsis. So, as we said, this is a partnership project.
We're not hearing her.
Can everyone hear me? Yep.
No. I can't hear you.
Can you hear me? They have lost me, Dom, and they're saying they can't hear me. Sorry, we won't be long. Can you hear me? Some people can. Or would you like me to keep going, Dom? Sorry, I'm just not sure if people can hear me or not.
I can hear you.
You can hear me?
I can.
Awesome. Okay, I'll just keep going. Sorry about that, everyone. As I was saying, this is a partnership project between the Queensland Paediatric Sepsis Program at Children's Health Queensland and the Queensland Family and Child Commission. So while the people involved in this project go well beyond those online today, your presenters are Dr Paula Lister and me, Bec Shipstone. Paula is the medical co-lead of the Queensland Paediatric Sepsis Program and the Director of Paediatric Intensive Care at the Sunshine Coast Hospital and Health Service. And I'm one of the Principal Research and Special Project Officers in QFCC's Child Death Prevention team. Before we begin today, we would like to acknowledge the Aboriginal and Torres Strait Islander peoples as the traditional custodians across the lands, seas and skies where we walk, live and work. We celebrate the diversity of Aboriginal and Torres Strait Islander cultures across Queensland and pay our respects to their elders past, present and emerging. We extend that respect to Aboriginal and Torres Strait Islander peoples here today. Today I am presenting from Brisbane, the lands of the Turrbal and Yagara peoples, and Paula is presenting from the beautiful Sunshine Coast, which is Gubbi Gubbi country. In terms of the format of the presentation, Paula is going to begin by defining and describing sepsis and discussing the problem of sepsis mortality in the paediatric population. She will then provide a brief overview of the study design and cohort. I will talk through some of the complexities involved in identifying sepsis in cause of death data, as well as the international method for identifying sepsis-related deaths used in this study. I'll then share some of our findings and in particular highlight the value of linked data in efforts to accurately identify the incidence of sepsis mortality. Please be aware that these are preliminary findings only, and so they will likely differ slightly from our final published findings. Paula will then conclude with some thoughts on the benefits of interagency partnerships in sepsis prevention efforts. I'll hand over to Paula now. Thanks, Paula. Paula's still having trouble. Would you like me to wait? Sorry, just a moment, everyone. We're just having some technical difficulties. coming. Okay, well, sorry about that. Over to Paula to talk about sepsis.
Yes, thanks, Bex, and I'm sorry about the technical difficulties. Look, the first couple of slides that I'm going to talk about are really just to share the awfulness of my day job, which is how important sepsis is, how devastating it is for our patients, and how difficult it is to try and prevent and treat. So first off, what is sepsis? Well, it's infection, often your common or garden types of infections like gastroenteritis or flu, and in this era of sort of middle of a pandemic, things like COVID, where the host immune response to that infection becomes dysregulated, and as a result of that, we develop organ dysfunction. And when that organ dysfunction involves a cardiovascular system, it's called septic shock. Now, the importance of the escalation and the progression of the disease is that the mortality rate goes up as you move from normal infection into sepsis. And we know that for children, a quarter of the children that die in pediatric critical care units die from sepsis, and very few children die anyway, so that's an enormous number. So it's an important part of our job as intensivists to look after septic children. Now, certain things are associated with risk, and those are being particularly young, having pre-existing comorbidities. But I do want to add here that 50% of children in Australia who have sepsis were previously well, and a third of those who die from sepsis do not have pre-existing mortality. And there are a number of other demographic, socio and economic factors that affect the incidence of sepsis. We know that our rural and remote communities are overrepresented, and we know our indigenous communities are overrepresented. Next slide, please, Beth. So, how big is the problem? Well, it's enormous. So this is data from 2017 from WHO, who looked at estimates of global sepsis in 2017. 11 million people died from sepsis, and 3.4 million of them were children, which equates to a child dying of sepsis around the world, 1 in every 9 seconds. So a couple of hundred during this morning's talks. So that was enormous, and WHO therefore made a resolution inviting member countries of WHO to please prioritise sepsis and tackling of sepsis, and Australia was an early adopter of that. And as a result of that, the Australian Commission on Safety and Quality in Healthcare has brought out sepsis standards in July of last year. Now, part of their commissioning work for that involved this 5-year study which looked at the epidemiology of sepsis, and it shows it's still a big problem here in Australia. There are nearly 500,000 septic patients, including adults and children, within our populations in hospitals over 5 years. And if you had sepsis versus those patients who didn't have sepsis, you were 10 times more likely to be admitted to ICU and 11 times more likely to die. Those are pretty stark statistics. Next slide, please, Beck. And pediatrics has some unique difficulties. It's pretty difficult to spot sepsis early, and childhood infection is really, really common. So how do you see that one child is going to get sepsis out of the 1,500 children who presented with cough and colds? Part of that is involving parents and public awareness. And unfortunately, when the George Institute did surveys of Australians and their understanding of sepsis and compared it to other diseases like HIV and breast cancer, they found that in the middle of a pandemic, where we are all talking about infection and viral infection every single day, only 60% of the population had heard of sepsis. And when you narrowed that down to the population who are of parenting age, fewer than half of them had ever heard of it. And when you drill down even further, fewer than 20% even knew it was related to having an infection. And the difficulty with this is it's easy to spot late sepsis, but our ability to do anything about changing the outcome there is very small. Those kids have poor outcomes, whereas if we can spot it early, we have a better chance of improving outcomes. So there is real treatment and real prevention that can happen. Next slide, please, Beth. And this is data from Queensland's Quality Council, where over sort of 5 years, they looked at the reported serious critical events, and there were 28 of them. Now, the first thing to note is that's very few, and we know that critical events are often underreported. But when we looked at these critical events, 23 of these babies or these children died, and the remainder had permanent harm that was a consequence of this. And when they looked at the things that had happened in the treatment of the children, the multifactorial gaps in care, and they related to delay in the recognition of treatment, so things like diagnostic error or not monitoring adequately. They talked about systems failure, where, for example, guidelines or policies didn't deliver, where there was inadequate escalation, where the communication was inadequate. And then there were real individual human factors related to healthcare professionals, where cognitive errors or knowledge-based errors happened. So sepsis and the treatment of sepsis, it's difficult to recognize, it's difficult to get there early. We know that if you get there early, you can change the outcomes. But in doing that, there are so many layers to that process that things can go wrong and you can end up with poor outcomes. Next slide, please. Thanks. So I'm trying to give you a flavor that understanding sepsis mortality is multi-layered and it's nuanced. And we know that sepsis coding is very poor and it under-recognizes the amount of sepsis that is out there, and that is particularly true when it comes to mortality and correctly identifying sepsis as part of that of a child's death. We know there is minimal, in fact probably no Australian national level reporting of sepsis incidence and mortality, and we know there are no population-based studies of sepsis mortality in children. Those that we have are either hospital administration-based or public hospital administration-based, or even worse, just intensive care-based, because that's where we have the data. So the accurate surveillance of sepsis mortality is important for us for a program like myself, which is tasked with reducing the burden of sepsis in our pediatric population. So if we can't survey it accurately, then how on earth am I going to track what we're doing and whether we're having any impact at all on improving outcomes from sepsis? So next slide, please, Beck. And I just wanted to point out that this problem is not unique to Australia. This is around the world. The difficulties in coding for sepsis and the difficulties in understanding, in having sepsis recorded as a cause of death is worldwide. So this is data from the UK confidential inquiry, Just Say Sepsis, in 2015, where they took a sample of prospectively identified adult patients diagnosed with sepsis. So these definitely were diagnosed with sepsis with clinicians at the time. They took a sample of 500 or so of them, and a fair number died, 159 of them died. Now, that there weren't death certificates in all of them, but there were about 100 or 105 death certificates related to those deaths. 42 of them, which is about 25%, had sepsis mentioned on the death certificate. The rest did not. And when they reviewed those that did not have sepsis even mentioned on the death certificate, they found that actually probably 81% of them would have been changed to add sepsis by the reviewers, which I think is significant. So this is a global phenomenon around the world, that we're not coding properly and we're not picking up and recording sepsis deaths properly. Next slide, please, Beck. So we have, and I'm so excited by it, we have managed to do something incredible here in Queensland. We have my program, which is with the Children's Health Queensland, and I'm the Queensland Paediatric Sepsis Program. We are partnering with the Family and Child Commission, and we're looking at the incidence and the factors associated with child deaths from 2004 through to 2021. And this is a population-based study that's using hospital administrative data and death data. So we're going to build up a much more comprehensive and much more accurate picture. So the child death register is obviously maintained by the QFCC, and it started in 2004, and we've got sort of, I think, over 8,000 cases in there, and it's a mixture of birth, registration data, coronial information, and information from other government organizations or agencies that have pertinent information about that child's circumstances of the death or the death itself. So it's a very comprehensive look at the death circumstances, and we managed to link that now with perinatal data, hospital admitted patient data, and emergency data. So we're going to get a really rich resource which we can then mine. Next slide, please, Beck. And so what we're looking at are all children, so birth to 17 years, who've died from sepsis. And the coding for sepsis, either those explicit codes or those implicit codes where we're including infection plus organ dysfunction. And we are excluding some pragmatically, some cohorts, and those are infants who never leave hospital, who die before they've left hospital, because often those include the pretermers or children with congenital anomalies, etc., where sepsis is really a different type of condition in those kids. We are excluding those who are born unexpectedly at home in poor condition, and we're also excluding kids who are known to be on an end-of-life palliative pathway, because there would be a ceiling of care. And we know that sepsis often is the terminal event for these patients, but you wouldn't necessarily be treating it in the same way. So we are going to be excluding those. Next slide, please, Beck. I think it's actually over to you, isn't it?
Forgot to take myself off mute. Okay, so to understand some of the complexities that are involved with identifying deaths due to sepsis in cause of death data, and Paula has touched on those that we're seeing in the research literature, but it's first necessary to have a bit of a chat about how deaths are coded and reported. So in Australia and internationally, cause of death information on a death certificate, autopsy report or coronial findings is coded using the 10th revision of the International Classification of Diseases, or ICD-10, and the Australian modification of ICD-10 is also used to code morbidity data from inpatient and outpatient records and emergency presentations. Now, importantly, in coding causes of death, the underlying cause of death is selected from the conditions that are reported on the death certificate. And the underlying cause is defined as the disease or the injury which initiated the train of events leading directly to death. In publications that analyse cause of death, it is the underlying cause of death that is predominantly reported. But when it comes to sepsis, this gets a little complex, because even when sepsis is explicitly mentioned on the death certificate, and we know oftentimes it is not, sepsis is rarely the underlying cause of death. This is because in most sepsis cases, the underlying cause is attributed to the underlying infection, or in cases where the child had pre-existing medical complexity, it is attributed to that background chronic condition. So I've illustrated the issue here. So the graphic on the left shows the underlying, the intermediate, and the immediate causes of death on a standard death certificate. And on your right, you can see that the underlying cause of death in this case would be attributed to the gastroenteritis, even though sepsis is identified on the death certificate. So this shows that standard methods for reporting mortality statistics, that is, by underlying cause of death, will absolutely not accurately identify many sepsis cases. So in the Queensland Paediatric Sepsis Mortality Study that we're undertaking, even when it was explicitly identified on the death certificate, sepsis was coded as the underlying cause of death in only approximately a quarter of the cases. So a related problem that Paula has already alluded to is that while sepsis may not be explicitly documented on the death certificate, both the acute infection and the consequential organ dysfunction may be. So if we recall, sepsis is defined as new organ dysfunction due to an acute infection. So in cases such as the one shown on the slide, sepsis is implied because of by the combination of the infection, in this case the rotavirus, and the organ dysfunction, in this case the acidosis and cardiac arrest. So again, the standard underlying cause of death approach to analysing and reporting on causes of death will simply not identify these cases as sepsis. To accurately quantify the incidence of sepsis deaths, all cases in which sepsis is either explicitly documented on the death certificate or cases where sepsis is implied through the presence of an underlying infection and consequential organ dysfunction should be identified. And this requires multiple cause of death analysis using the underlying, intermediate, and immediate causes of death. So I'll just take you through the internationally accepted method for identifying sepsis in cause of death and hospital admission data. And this has been used in most epidemiological studies of sepsis since the early 2000s. And what they do is they classify sepsis into two mutually exclusive groups, explicit sepsis and implied sepsis. So the table that we've popped up on the slide shows this international method, and it also shows our modification of the method that we are using in the paediatric sepsis mortality study. So broadly speaking, what we've done is we've expanded the inclusion criteria to overcome some known limitations in both cause of death certification and in the coding of sepsis and infections. So according to the international method, the identification of explicit sepsis requires that an ICD-10 code referencing sepsis is included as the underlying or a chain cause of death. In our method, we also included cases where a text search of the uncoded death certificate identified the term sepsis, but an ICD code referencing sepsis had not been included. And sometimes that is not included due to the intricacies of coding rules. As we linked hospital admission data for the final admission during which a child died, cases were also classified as explicit sepsis if an ICD-10 code referencing sepsis was included as a principal or other diagnosis. When we turn to implied sepsis, using the international method, cases classified as implied are identified by an ICD-10 infection code listed as the underlying cause of death and an organ dysfunction code listed as a chain cause. We expanded this to include cases where the infection was listed as an underlying or a chain cause. And the reason we did that is to pick up on those cases where the underlying cause has been attributed to the complex comorbid condition. We also included cases where a text search of death certificate data revealed the term multiple organ failure, as there is no specific corresponding code for this in ICD-10. So in terms of our study, what we did is we began our sepsis screening by identifying all children who had an infection code listed as either the underlying or a chain or a contributing cause of death. And this ensured that we included all child deaths where infection played a contributory role and therefore sepsis was at least possible. There were 1,204 child deaths where infection played a causal or contributory role in the death. We then excluded those infants who had died in hospital having never left after birth, as well as those children known to be on a palliative pathway at the time of diagnosis. We then used multiple cause of death and linked hospital admission data to categorise the deaths. So of the 712 infection-related deaths after exclusions, there are 299 cases of explicit sepsis and 128 cases of implied sepsis. And then we have those 285 non-sepsis infection-related deaths remaining. Importantly, in 203 of the included cases, the death occurred in the home environment or very shortly after presentation to an emergency department, and the remaining occurred in hospital. So linked hospital admission data was available for 437 of the in-hospital deaths. And our data linkage there was affected by the age of the records, and that's because private hospital admissions data was not available prior to 2007. So looking here, I want to show you the immense value that we see in linking cause of death data from the Child Death Register with hospital admissions data in increasing the identification of in-hospital deaths due to sepsis. So sepsis was explicitly recorded on the death certificate in 159 in-hospital deaths. However, when we linked that hospital admissions data, it increased the number of explicit sepsis cases by nearly 50%, from 159 to 237 deaths. And similarly, due to the increased identification of organ dysfunction in hospital admission data, the number of implied sepsis cases increased by nearly 30%, from 85 to 110 cases. And this obviously meant that the remaining non-sepsis infection deaths decreased substantially by nearly 53%. So data linkage is not only valuable in increasing the identification of in-hospital deaths due to sepsis, but as we've previously mentioned, 203 deaths, nearly 30%, occurred out of hospital in the home environment or en route or very shortly after presentation to an emergency department. These deaths are always missed in hospital admissions data and are missing from the vast majority of paediatric sepsis studies, which have relied solely on those health data sets. Data linkage studies are therefore really invaluable in piecing together the puzzle of paediatric sepsis. So I'll now hand back to Paula to conclude with some remarks about the value of interagency partnerships in sepsis prevention.
Thanks, Beck. I think we are incredibly excited by this partnership because we know that sepsis is eminently treatable and poor outcomes are eminently preventable. And that is a core piece of business for agencies such as the QFCC and others who will be from other jurisdictions who will be listening as part of this conference. I think really exciting for me is, first off, we have actually established methods to correctly identify these patients from hospital and death records, and that method is scalable across the country. So we could actually get really impressive, comprehensive picture from throughout Australia and New Zealand, and that to me is extraordinarily exciting. And next up is we could probably be doing this. This is paving the way for a whole lot of future research, understanding the importance of the demographic and socioeconomic factors that affect pediatric sepsis, and we'll be able to do those deep dives in the future. But the key thing for me and my program is that 30% of what we thought is that 30% of cases are completely invisible, that we've never been able to access, influence, know about. And now suddenly we have a whole 30% more of cases that we can try to understand, to piece together the puzzle, as Beck says, of sepsis. So working together with agencies like the QFCC and ourselves, we are able to build and increase our sphere of influence into areas where we can't normally influence at all. So together we are actually building a much bigger, more comprehensive picture, and we will be able, therefore, with our scope in terms of reducing the burden of pediatric sepsis, we'll be able to influence a whole lot of areas which we couldn't do before. So the partnership together is incredibly exciting, and I do hope that as an example, this would be the first of many for the QFCC and for ourselves. So thank you very much for listening.
Thank you.
Thank you so much, Rebecca and Paula. That was a wonderful presentation, and I really look forward to the results being made public in the future. Okay, next up we have Mandy Gibson. Mandy is from the Australian Institute for Suicide Research and Prevention at Griffith University in Queensland, and today we'll be speaking to research around linking First Nations suicide mortality rates with community cultural connectedness data. Over to you, Mandy.
Thanks very much. Just checking the screens all working.
Yep.
Oh, wonderful. Thank you so much. I'd also like to acknowledge I'm presenting on Yagara Jarana, the country of the Yagara people. I'd also like to pay my respects to their elders past and present and acknowledge the enduring connection on the land we're meeting on in various parts of the country and overseas today. I'd also like to acknowledge the harms caused by actions of historic and continued colonisation, which have sought to diminish that connection, the impacts of which are seen in the disproportionate burden of suicide borne by First Nations communities today, and in many of the other areas where we're seeing First Nations young people overrepresented in adverse outcomes. I'm sure many people listening today are very well aware of the poorer outcomes experienced today across the many issues that people are presenting with regards to. of particular concern with suicide is that the gap between First Nations and non-Indigenous suicide rates increases the younger the age cohort under examination is. So while overall the age standardized total population rate is a bit over twice as high for Aboriginal and Torres Strait Islander people, for young people under 15, that rate increases to almost 8 times as high for their non-Indigenous peers, which means that 1 in 3 young people who died by suicide in our state last year, of youth suicides in our state last year, were Aboriginal and Torres Strait Islander young people. So reducing Indigenous youth suicide mortality is critical to reducing our total and national and state youth suicide mortality rates. And of course, having meaningful closure in the life expectancy gaps for First Peoples in Australia. Also, we know that while suicide rates are increasing in all age groups, this continues with young people in Queensland and in Australia, which is really noticeable when many of the other causes of childhood death we're actually able to see decreases. So reducing suicide is critically important to actually reducing our overall pediatric mortality rates. So even though we have known about this for decades, we have seen very little evidence that the First Nations youth suicide rate is actually meaningfully reducing, or even the gap with non-Indigenous peers is even reducing. Suicide remains the leading cause of death for Aboriginal and Torres Strait Islander young people aged between 5 and 17 across this nation. So while we've known about these disparities for decades and decades, there's actually very limited evidence of effective suicide prevention models for First Nations communities. We recently conducted a systematic review of all First Peoples suicide prevention programs globally. And in that process, we found only 3 that examined and found improved outcomes in suicide-related indicators for Aboriginal and Torres Strait Islander young people, and then one additional one that looked at adults in Australia. So there's obviously many reasons for this mismatch between how severe and how complex we know this problem is, and how long we've known about it, and how little data we've, a little evidence of meaningful change we've actually been able to produce in that time. But one of the key reasons that is increasingly of focus in suicide prevention is the fact that there's a significant mismatch between the data we use to understand and in turn try and prevent First Nations youth suicide, as it is very much built on the data and experiences of non-Indigenous young people. For example, here in Queensland, looking at the data of people who have died by suicide, we know that First Nations young people, compared to their non-Indigenous peers, were less likely to have ever experienced symptoms of mental illness, less likely to have ever communicated intent, and in some studies, even less likely to have had a recent suicide attempt. As these are both the key indicators and data we often look for in our analyses. And from a clinical point of view, they're also the key indicators we use in screening and triaging to determine which young people get help. So it's not surprising that Aboriginal and Torres Strait Islander young people who've died by suicide were less likely to have ever received any mental health treatment or psychosocial support compared to their non-Indigenous peers. So data like this is being increasingly used to acknowledge that we need to, move on from the traditional strategies that seek to just pick out which young people need support and treatment, and move to models that also include protective effects and preventative mechanisms operating at the whole of community level. But predominantly, this data shows us that regardless of which level of intervention or where we're targeting our programs, it is really critical that we expand from the traditional forms of data we are using to understand and indeed prevent Indigenous suicide, that we need First Nations specific data and models to intervene. Because we already know that many key factors and key risk factors for suicidality are either excluded or at least fail to be centered within many traditional models of suicide prevention and triage. Most notably here, of course, are the experiences of discrimination and racism. We already have a lot of research that finds that this experiences of racism and discrimination are associated with greater suicidal ideation, attempts, and various other indicators of suicidal thoughts and behaviours for Aboriginal and Torres Strait Islander people of all ages in Australia. With some studies actually finding the relationship between racism and discrimination to actually be stronger and have greater influence on suicidal thoughts and behaviours than many of our very traditional risk factors, such as health issues or income-related issues or drug and alcohol-related issues, and even some studies finding the gender differential, having less male rates not being much higher for First Nations young people compared to the influence of racism and discrimination. So with such strong effects and notable effects of these culturally specific risk factors on suicide, we want to build on these findings to examine other culturally specific data and critically to look at preventative and protective factors that can underpin our interventions to reduce these rates. And I guess putting the academic data and literature aside and the reasons for doing this from that point of view, just going back to our initial acknowledgement of country. In suicide prevention research, it is broadly accepted and fairly widely stated that the suicide rates experienced today are the result of colonial actions, of community dispossession and cultural dislocation, that these are in fact causal. Yet as researchers, we haven't commensuratively actually applied that logically. We should be looking at community empowerment and cultural connectedness to alleviate these effects. These have actually been quite limited in our focus and in our intervention and evaluation designs, in fact. And that is very much the focus of this particular research project I'm presenting some of today. Broadly, to examine the relationships between data on cultural connection with suicide mortality for Aboriginal and Torres Strait Islander young people. Of course, there are many challenges trying to access cultural data, particularly at the community level as is needed for looking at suicide mortality. Of course, there are challenges with identifying individuals, especially in small areas and remote locations. So our friends at the National Centre for Socio-Economic Modelling have used aggregated survey responses from the National Aboriginal and Torres Strait Islander Survey. I'm sure many people are aware of this survey with the many epidemiologists here. But this survey is conducted every 6 years, completed by First Nations residents of 15 years and older. And it looks at general health and well-being and social support. But it also looks at cultural activities and cultural expression and engagement and how individuals are applying that in their lives. So friends from NATSM have then used those aggregated survey responses and benchmarked them and validated them against census data, so, indicators such as household size and age, in order to gain reliable small area estimates of social and cultural indicators, which are then reweighted for Aboriginal and Torres Strait Islander populations at the SA2 level, so the statistical area level 2, so the second smallest of the ASGS. And they've been able to do that in a way that doesn't identify individuals. I won't further explain this methodology, but the link is there. Please contact me if you want to talk about how to use that in your own studies or different analyses. Love to have a yarn. So for this study, we're comparing Indigenous youth suicide mortality rates by the percentage of Indigenous language speakers in each SA2. And we're looking at cultural aspects of social capital. So a multi-item index that looks at attending ceremonies, Indigenous specific organizations and activities, as well as general social capital to perceived ability to give and receive support within their local area. And we're also looking at discrimination, comparing suicide rates where more than 25% of the First Nations residents report they experienced racial discrimination in the previous year. And here in Queensland, the main mortality database we're using to look at, calculate age-standardized suicide rates for First Nations young people is the Queensland Suicide Register. I believe it's actually the longest running suicide registry in the world. We have cases and information on all suspected suicides going back to 1993 in Queensland. And in this process, we collect information from a number of sources from police and from coroners and a number of other places in order to collect up to 400 different variables relating to the evidence of probability of suicidality and the literature and keeping that up to date with what we know about suicide and predictive variables. So we use that in a flowchart to classify the probability of suicide into beyond reasonable doubt, probable, possible, or unlikely. I'm just using the first two, beyond reasonable doubt and probable, for this particular study. And we have additional cross-checking for First Nations identification at the Registry of Births and Deaths and Marriages. So with the QSR database, we're able to then code and calculate age-standardized suicide rates at the SA2 level for Aboriginal and Torres Strait Islander young people. And using this data, we're also able to compare suicide rates based on economic resources using the CEFA indices, as well as remoteness, comparing suicide rates in cities, metropolitan areas versus regional and remote. So for those of you that don't have to look at forest plots too often, where the purple pink line is, that shows a rate ratio of 1, would say that any area where the black error bars exceeds that line, we would say those are statistically significantly different, those two rates, to the suicide rates in the areas of high and low cultural connectedness variables or general community variables. So the first thing noticing here, of course, is that the cultural aspects of social capital, that communities in which First Nations residents had greater involvement with cultural events, activities, and attendance at cultural organisations, and general ability to give and support each other in their communities, that Aboriginal and Torres Strait Islander young people died by suicide at a significantly lower rate, which is rather interesting when you can see that socioeconomic resources, that difference was not statistically significant. So the social and cultural resources have influenced youth suicide in a way that social and economic resources such as income and education have not. But of course, the most striking thing here is looking at the influence of discrimination. So communities where more than 25% of the Aboriginal and Torres Strait Islander population reported experiencing racial discrimination in the previous 12 months, First Nations young people ended their lives at a rate more than 2.5 times as high as communities where fewer people experience discrimination. So while these findings are fairly stark and provide somewhat promising evidence that Indigenous specific data can provide important information to help guide both our understanding and our prevention of First Nations suicide, it is important to acknowledge that our variables, particularly the cultural social capital variable, may have some underlying correlations with other protective factors or other general community level risk factors. For example, greater propensity to engage in Indigenous specific services may reflect more services to engage with, or greater support to share with community and greater sense of capacity to share may just reflect that there are more resources to share. So for our next study, using in these analyses, we wanted to compare the high and low levels of these culturally specific protective factors in the communities with the most social and environmental disadvantage. So those with the least social and economic resources, so income, education, overcrowding, job type, regional and remote services, communities with the least services and the furthest distance to access healthcare and shops and various other supports, and the communities where the most Aboriginal and Torres Strait Islander residents reported experiencing discrimination. I'll leave this slide here for a bit. I realize there's a lot going on. But firstly, interesting here that while we saw on the previous slide, there was very little difference in communities with high and low levels of Indigenous language use, in all of the 3 communities with the greatest social and environmental disadvantage, fewer young people ended their lives by suicide in communities where there was higher language use, suggesting that maybe some culturally specific protective factors actually have the greatest influence where there is most disadvantage and provide the most support for young people to buffer against the, I guess, social and environmental legacies of colonization through this area level disadvantage. But what strikes me here is looking at the effects on discrimination, that both the Indigenous language use and the cultural aspects of social capital had the greatest influence on the rates at which Indigenous young people took their lives in the communities where there was the most discrimination, where more Aboriginal and Torres Strait Islander people reported recent discrimination, suggesting that the adverse effects of discrimination may be particularly amenable to change through cultural interventions, or that there is a meaningful buffering occurring against the multiple indicators that we see disadvantage continuing for First Nations people in this country, that providing cultural protective factors may have a unique buffering effect on suicide, as well as many other areas that we see significantly poorer outcomes as a result of disadvantage and discrimination. So I realize I'm just going into the break time, so I will wrap up fairly quickly, acknowledging that, of course, these are very initial and preliminary findings. But nonetheless, this really does, using this novel form of data that is not what we classically look at as suicide prevention researchers. But nonetheless, this opens up very new avenues for understanding and addressing Indigenous suicide mortality disparities, whether that's through society-wide efforts to reduce discrimination as a serious public health concern, or whether we look at Indigenous language rejuvenation and supporting cultural community expression programs. But this provides really important information, particularly when for First Nations young people, we have very little evidence of effective programs to reduce these disparities, and we have no evidence that we have meaningfully made changes in 2 to 3 decades that we've known about this challenge. So while I want to acknowledge, most importantly, that while it's very easy to say this is new findings or this is novel research, we're a bit guilty, I know, as researchers, of not sitting to acknowledge that this is in no way new knowledge on these lands, that the importance of using a cultural connection to buffer the harms of colonization has been promoted for decades and decades and decades. And the importance of connecting to culture to know who you are and imagine a positive future for yourself and see indigeneity as a positive thing in the 22nd and 23rd centuries and the positive effect of young people, that has been known on these lands for millennia. So thank you very much. I'll hand back over. I believe we're going to morning tea now. And I think question time is after the break, I believe. So thank you very much.
That was a wonderful presentation, and thank you again for your important research in this space. We've still got a long way to go to reducing the suicide rates, particularly in our Indigenous young people. Okay, so please keep your Q&As coming through the Q&A section at the bottom of the bar. Look, we are going to take a short break. We are going to pinch a little bit of time. So rather than start at 11:25, we will actually start at 11:30. So a quick 10-minute break, and we'll be back with our future presentations. Thank you. Hello and welcome back. Continuing with our session on data linkage and knowledge sharing, we have Professor Kirsten Valmer from Jemison Trauma Institute at QUT. Kirsten is going to present today on the deeper insights that can be drawn from linked injury data. Over to you, Kirsten.
Okay, I'm hoping people can see that screen.
Yes, we can.
Pop it into presenter mode. Okay, you can see that okay? Brilliant. Okay. Thank you for the opportunity to present today. So I'll be talking about some insights from linked injury data to improve our understanding and prevention of child deaths. So when I was asked to present at the conference on this topic, I had to pause for a moment and decide how best to make use of the 20 minutes to break the topic down. I decided it'd be helpful to first talk a little bit about what we mean by linked data and linked injury data in particular. We've had some good insights from some of the previous presentations, so this will just be some supplementary information to that. I also thought it'd be helpful to discuss how we could use this linked data then to provide a more comprehensive understanding of causes of death, and then tackle how having an understanding of causes of death could then enable more insights to inform prevention. So I'll start with providing some broad background about what we mean by injury data linkage to start with. So two of the valuable resources in data linkage are the international and national data linkage networks. And I've got some links here, and I'm happy for these slides to be shared with attendees as well. So these two links have some really useful resources about processes, links to different linkage units around the world and research papers that have used data linkage approaches. And there's further information about the three main integrating authorities in Australia who provide national data linkage services at these sites as well. So when we're talking about linkage, we're essentially talking about the process which combines information about individuals across a range of data sources, whereby a linkage unit will merge records together which meet certain criteria for a person, and they assign person keys to the relevant records. And then data custodians can provide the content information for those records, minus the person identifiers to researchers and agencies requesting the data. The challenges lies in deciding which records are relevant to the condition of interest and which are irrelevant, particularly in the health area where a person might have multiple interactions with a health service for a range of conditions. So we've recently published a paper to provide some guidance about this, about how to use linked data in the injury field, and it touches on some of these complexities. And we welcome further conversations with anyone in this space that would like to discuss this further as well. So this is just a simplistic example of what we can do in the injury data linkage space. At JTI, we haven't explored community health data in much detail. We tend to use more acute care data, but linkage to community health data sources such as the medical benefits scheme and pharmaceutical benefits scheme are certainly well used in other areas. We've got many studies underway which identify people who have had an injury which has either been attended by a pre-hospital service provider, such as an ambulance or aeromedical retrieval, people who have sought emergency care or been hospitalised for an injury or died from an injury. For these people, we seek all of their records related to that injury event, such as the data from the emergency dispatch system, clinical records captured by paramedics or retrieval services, emergency department clinical records, hospital discharge coded data, death registry data, coronial data, rehabilitation data, and so on. We then seek all records after an index record has occurred, an index event, and follow those patients up for a period of time so we can investigate ongoing health service use for further treatment of injuries, for complications, or even for new injury events. When we bring together data across a range of health data sets, we can get a really comprehensive picture of an injured child's injury event, their clinical journey, and their treatment and outcomes. So, for example, in health data, we get a range of demographic factors. We get information about the times and dates of their service use. We get diagnoses, procedures, information about complications. We can access information about the costs of that treatment, the healthcare costs. We have information about the causes of injuries and the locations where injuries occur. We can also see how people move across different facilities and what their readmission patterns are. So some of the types of questions that we would ask would be things around, firstly, what are the main causes of injury? So we might look across age groups or across regions or across vulnerable groups. We might be interested in looking at what injuries occur and what procedures are performed with those, what the patient journey is across the health system, how often they represent for treatment of the same or new injuries, and so on. So I'd like to apply this knowledge now of linked injury data to how we can use this to improve our understanding of causes of death. So this was just drawing from the Queensland Child Death Report produced by QFCC. And we can see here there's an average of around 90 external cause deaths per year over the time period. And this was just downloaded from the supplementary tables that are provided on the website. So the top 5 external causes for top 5 external causes are transport-related causes, suicide, drowning, assault and neglect, and threats to breathing. And these are the patterns for those top 5 causes. Over the 18-year period, there were 1,605 cases. Identifying significant risk factors and patterns in a cohort of 1,600 odd cases is challenging, and findings, it's particularly difficult where we've got small numbers of cases to look at what risk factors may be. We may get artificial findings with a small case load like that. So how do we broaden our understanding of the factors contributing to serious injuries and death? So firstly, just to set the scene for the data, I'll be referring to for the next few slides. I'll be drawing on data we've compiled for a larger injury study where we've examined injured patient journeys, treatments, and outcomes at JTI. So essentially, the data that we've compiled includes all injury-related presentations to emergency departments and hospitalisations in Queensland between 2012 and 2017, and all of the follow-up injury care. The cases were selected if they had an ICD code in the range SOO to T75 or T79, which are the common ones used when we're talking about community injury. And that had to be a principal diagnosis at ED or for hospital. And then we sought all follow-up care records for patients as long as they met one of those criteria. We've got, for this data, we're looking at all ages, but for this presentation, I've extracted children under the age of 18. And our data is currently being updated to include data up to the end of 2021. So we've got a longer time frame of data, but this is only on the 2012 to 2017 data. The data linkage was kindly performed by the Queensland Health Statistical Services Branch Data Linkage Unit, who have been mentioned here previously. So at a basic level, even in the absence of data linkage, and this is purely just looking at the numbers of ED presentations and injury hospitalisations that we had in our data set, the average per annum. So at a basic level, in the absence of data linkage, we can see the extensive amount of cases and information that could be provided from non-fatal injuries just by the sheer size of the difference. So across the 6 years of data for which we have injury, when we look at those 6 years, the average per year number of deaths in 2012 to 2017 was around 80 deaths per year. We had around 20,000 injury hospitalisations. This is just Queensland alone. And we had around 115,000 emergency department injury presentations in Queensland alone for children under the age of 18 years. So in other words, for every death, we have around 250 injury hospitalisations and almost 1,440 injury-related emergency presentations. Looking at the trends over time, we can see the rising number of both emergency presentations and hospitalisations. Deaths are also on this graph in red, but due to the sheer size difference, we can't even see those, the red colours on this slide. Circling back to the graph that I had at the start, the top 5 external causes of death, just note the numbers on the x-axis here for the number of child deaths. I've examined the data we have for children in our data set and grouped the external causes and intent into similar categories. We actually use quite different categories, still ICD in hospital, but we'll often describe things more in terms of the mechanisms and intent separately. With the death data, intent and mechanisms when describing child deaths are often grouped in together into categories. So I've replicated that with the hospital data and grouped our data in that same way so that we can represent it as transports, assaults, threats to breathing, intentional self-harm and drowning. So intentional self-harm equivalent to suicide and drowning. I won't elaborate on the other causes that we see in hospitalisation data. So these aren't the top 5 causes for hospitalisations. They're the top 5 external causes in deaths data. But just so that we can see those kinds of comparisons, I've pulled these out for the hospitalisation data over time. So this slide here gives you a perspective on the size of the difference in numbers for deaths and hospitalisations for those different causes. It's challenging to see the patterns because of the differences, but hopefully it demonstrates the opportunities that are apparent in delving into the data sources to understand those broader patterns around causes of injury deaths that could be drawn out if we were to also look at hospitalisation deaths. You can see the size difference in terms of the numbers of transport hospitalisations compared to transport deaths, and the number of assault hospitalisations compared to assault deaths, and so on. The much larger bars are those ones that extend across the slides are the hospitalisations, and the much smaller bars are the ones represent the deaths in those years. Drawing out the top 2 causes of death for children in Queensland, I've drawn the deaths on the secondary axis and hospitalisations on the primary axis here over time. Deaths are in the dotted lines and hospitalisations are in the complete lines, and transport is in red and suicide is in blue. So while there appeared to be a bit of a drop in transport-related deaths for the several years that we're looking at, we aren't seeing that same trend in hospitalisations. In terms of the patterns of intentional self-harm, we see rises in hospitalisations over time, while for deaths, the pattern over these years was a little bit variable. Obviously, within all of these injury-related emergency presentations and hospitalisation causes, we can delve into many different factors, which I outlined earlier, to understand the risk, severity prediction, etc., with a much larger number of cases. So we can draw that out. We can draw out a much more significant amount of information about hospitalisations with those larger numbers than we can when we have the smaller numbers of deaths. We can even specifically examine the cohort of children which died during the hospital encounter within our linked data. In our linked data for that time period, there was 188 deaths where a death was recorded in their final record. So we can see that the majority of children had more than 2 previous emergency department presentations and more than 2 previous hospital encounters when we look at that total row down there. So this presents for those children who died, what the average number of records they had in terms of ED presentations and hospital admissions, and what the maximum number that we saw in our records were for any particular child. And it's broken down into those same categories. So we can see for some causes, suicide, if I draw your attention to that, there was over 80 presentations to emergency departments and over 70 hospitalisations for at least one of the cases in our sample here. It's a lot of very rich data when linking backwards for cases. So while child death reviews often undertake those detailed case-by-case reviews, linked data does enable us to delve into this on a population level and link that data across the whole cohort and look at those cases for a more population level intervention opportunities. So this then leads me to the final part of the presentation as to how a better understanding of causes of injury deaths can enable prevention. The child death data is really the tip of the iceberg to understand injury causation. As we've seen here today, for every death, we have many more hospitalisations and emergency presentations. I haven't even gone into the other levels of the injury prevention pyramid, in that for every visit to a tertiary health care facility, we have many more visits to primary care providers, non-medically treated injuries, and near misses. Underpinning all of these incidents, we have people's knowledge, attitudes, and behaviours. Focusing in on just the pointy end of the pyramid misses the opportunity to understand child deaths in the broader context of the entire health service use trajectory, and misses opportunities to consider all of the various factors contributing to non-fatal yet similar causes. The data linkage is a valuable tool for us to depict the entire elephant through integration of key sources of information about a child's life and death. I focused in today on injuries and data sources coming from the health sector, as that's where my work lies. However, we do see many more examples when we delve into the data linkage field of linkage, the field of data linkage across many other health sectors, such as child protection, justice, education, social welfare, housing, and so on. So with the increasing availability of significant amounts of data and advances in data linkage technologies, we do have a vastly expanded opportunity to gain more comprehensive insights to inform child death prevention activities using data linkage as a methodology. More information here is available. I'm more than happy for people to contact me after the event. There's links there to our Jamison Trauma Institute page and our trauma program on the Australian Centre for Health Services Innovation, which is my home at QUT. So more than happy for that information to be shared. Thank you.
Thank you so much, Kirsten. Such a valuable piece of work that you're working on there. Kirsten is unable to stay for the question and answer session at the end, but we will happily pass on those questions and get responses back to people if you want to still continue to post in the Q&A section. Okay, next up we have Dr. Andrea Josipovic from the QFCC on the Queensland Child Death Review Model and how consideration of agency touchpoints can add additional insights to improve system responses. Over to you, Andrea.
Hello, welcome everybody. Well, thank you so much for having me. So before I dive into kind of what the Queensland Child Death Review Model looks like, I would firstly like to acknowledge the traditional custodians of the land on which we're meeting today. So the Queensland Family and Child Commission is located on beautiful Meanjin country, and they are the Turrbal and the Yagara people. And I want to pay my respects to elders past and present and to all future leaders, and acknowledge the hard work of my First Nations colleagues who work tirelessly to reduce overrepresentation in all child protection systems. Now, I thought I might just put a bit of a disclaimer out there around what I'm trying to do with this presentation. We had lots of discussions, so I do want to talk about kind of the background and the intent of the model that we have here in Queensland, just to sort of introduce it in particular, well, to people from within Queensland, but also importantly to people attending from other states and territories, because it's always really interesting to compare and contrast these models and figure out kind of what works about them, and then some areas where we can filter in, you know, other people's ideas, which would be amazing. So I'm really hoping for some input there in the question and answer session as well. Feel free to raise any kind of feedback or questions you might have that come from this presentation as well. So yeah, definitely talking about that, and then sort of going into in a bit more detail about the CDRB, so the Child Death Review Board, and the functions that it has, how the CDR team, so the Child Death Review team, supports the reviews that the board makes, and the findings and recommendations that they sort of provide over the year. And I will kind of introduce some of the key recommendations that were made in the last annual report, 2021-2022, and just sort of talk through some of those in a little bit more detail. And I'll talk about some of the research reports that have come out of those recommendations or are closely linked that have been commissioned by the board so far. And then I'll be talking through a couple of visual case examples, including timelines, which are sort of designed and presented to the board to help illustrate a child or young person's trajectory in the 12 months prior to their death. And then there's a little bit of information around further reading that might be of interest for people. I will say I'm really, really happy for these slides to be shared. So all of them have been have been through a quite thorough review process with the commission itself, and they're fine to be shared. So starting with the background, this model has been in place in its current function since the 1st of July 2020, following a really thorough review of individual agency findings with the death of a child. where there was a coronial inquest that was publicised and so on. But the recommendation that came out of that was that the Queensland Government considers a revised external and independent model for reviewing the deaths of children who are known to the child protection system. And with this caveat around, we usually have these agency review cases where there were system touch points in the 12 months prior to their death. However, if there is relevant information sort of leading up to what was going on there, the child death review team can kind of widen the scope if it's relevant further review. So the legislation that guides us in that space is first and foremost the Child Protection Act in Queensland from 1999 with, its various revisions and legislative amendments, and then the Family and Child Commission Act 2014 here in Queensland. Now, the reviewing agencies that we receive internal reports from are Child Safety, Health, Queensland Police Service, Queensland Education, Youth Justice, and the Office of the Director of Child Protection Litigation. So our legal representatives who make applications through the Children's Court. And those internal agencies provide their reports and other information, and then the Secretariat, so our team, collates that information and looks at systems responses overall across the board and provides a review to the Child Death Review Board, and they discuss it and make recommendations and findings there. So the composition of the Child Death Review Board is kind of like just illustrated in this little infographic. So it's chaired by the Principal Commissioner, the Commissioner of the Queensland Family and Child Commission, Luke, who did the opening of today's conference. It has to be a minimum of 50% non-government board members, and at the moment we're actually undergoing a recruitment process for new members to be appointed, because they're appointed for a period of 3 years, and we're nearly up to that by the 30th of June. We have to have obviously a good mix of relevant skills and experience. That could be from family law, pediatrics, child protection professionals, health professionals, and a number of other really important skills and areas of expertise. There has to be at least one Aboriginal or Torres Strait Islander member on the board, although there's a very strong sort of recognition that we would like more members to be First Nations members on the board. And members can be reappointed if they reapply after the 3-year period as well. So the functions of the Child Death Review Board, there's like obviously that review process that I already mentioned. So it's really important then to kind of pull together data and available research to identify some of the overarching themes and patterns, trends and risk factors that we do get to see in those reviews. And at times even carry out relevant research. And I'll get to that in terms of what research pieces have been commissioned so far by the board. And then there are the recommendations that focus on legislative change and improvement to the systems, policies and practice. And definitely there's a strong child death prevention element in that as well. And then those recommendations get monitored over time. In fact, at the moment, we are sort of seeking a little bit of an update on the 2020-2021 recommendations and the progress to make sure that these are tracking nicely. So a report is annually tabled to the Attorney General here in Queensland. And that happens on the 31st of October every year. So if we don't answer our phones on the 28th of October or something like that, you know why that is, because there's some mad last changes to the draft report, and it needs to be over to the Attorney General by the 31st of October every year, yeah. So in terms of the process, we receive and collate the reports. So that's the Child Death Review team. There is a review and categorization process that is very thorough, and there are 3 levels that we can kind of provide a categorization about. So the level 3 is the most in-depth level, where a lot of preparatory work has to be included. So there are complex cases where they definitely identified some opportunities for systems improvements and some good rich discussion around how child death prevention could function in the future, or could be supported in the future. Level 2, there are some areas of discussion. Again, there's a review report that gets provided to that, and then there's the level 1s where where it was found that the internal reviews by the agencies covered every aspect of the systems intervention sufficiently, and often that happens when a child died of natural causes, and there was very clear indication that the system's actions or inactions did not significantly impact the cause of that child passing away in the 12 months prior to their death. Then it gets allocated to a meeting. So the meetings happen in a financial year rhythm, so 1st of July till 30th of June. And so far we've had years where we had 5 meetings, and then this current year we have 6 meetings. And in that preparation time, the child death review team or secretariat, we analyse and prepare those review reports. And then any follow-up actions following the meetings, we carry those as well on behalf of the chair, and follow up on those. So some of the actions that have been recommended by the board, so this is a little bit of there are other ones that are sort of still in progress. So one would be on forensic orders. These are just sort of some examples. There's a strong recommendation around joint visits between child safety and Queensland Health, in particular in the postnatal care of infants, where that has been found to be really beneficial in terms of child death prevention. In the sudden unexpected death in infants, for example, will be one of those areas where that's been found to be really beneficial. Then the fitness to stand trial for our young people who are dealing with youth justice matters. That assessment around permanent decisions about a child's fitness to be held criminally responsible when they have a permanent disability. And then lethality indicators around identifying and responding to a parent threatening to kill a child in the context of domestic and family violence, and those lethality indicators that in the domestic and family violence research space get so often talked about, such as strangulation, threats to kill, and many others. So what do those reviews actually look like? So we receive the reports. Oh no, I've talked about that just before. Sorry. I think I just got my order. I went backwards instead of forwards. So findings and recommendations. So this is taken straight out of the last annual report, which was the 2021-2022 annual report. You can see that in total 55 cases have been reviewed. So if you then look at the numbers of how many of those were First Nations children, you can see 28, so 51% identified as First Nations, 22 were female and 33 were male. And then if you kind of think about Mandy's sort of discussion of suicide rates and that connection to culture, there's been definitely a strong recognition there that is one of the areas that can provide better protection especially for suicide. And then we were talking about, I guess, in Kirsten's presentation also around the cause of death. So, of course, from the data set, that's the even more pointy end. So for those children and young people, obviously, who had child systems intervention 12 months prior to their death, transport, fatal assault and neglect, 5 were unexplained. So that is the sudden infant death syndrome and undetermined at the point of their death. And I just want to say sometimes that does get determined later on, but we talk about unexplained at the point of review. Unknown causes, same thing, cause of death pending, not the same thing per se, but for us at the point of review, cause of death pending, and there is a strong possibility that gets determined after the point of review. 6 suicides, and then 6 drowning accidents. We received 190 internal agency review reports, and you can see the breakdown of who they were from. Obviously, the biggest number there is often for child safety. Queensland Health looks like, yes, they are. That's a really high number, and that is because they have 17 health districts, so the HHSs in Queensland, and sometimes children are seen by providers in more than one of those districts, and that accounts for the higher number there. But for every child who had system intervention or contact with the system in the 12 months prior to their death, child safety will provide a review. And then there are some on the other, in the other internal spaces as well. So education, youth justice, and DCPO as well, and Queensland Police. So the recommendations in the annual report, there were 6 in total. 2 were about workload, in particular with a focus on service accessibility and delivery, and in particular for rural and remote communities and First Nations families. So that was the focus, and there was a strong recognition that workload can have a significant impact on, I suppose, the capacity of the system to respond meaningfully, to understand and respond to children's needs. Recommendation 3 was about continuity of care for children with complex needs, and that is in particular in relation to children engaging in high-risk activities. So, you know, you would sort of look at behaviours such as engaging in criminal behaviour, drug use, suicidal ideation, and long-term experiences of trauma, abuse and neglect. And so that is how this recommendation was came about. The recommendation 4 was about domestic and family violence. And again, it was in relation to, in particular, so there's obviously quite a lot of activity going on in terms of recommendations around domestic and family violence, also with other institutions publishing reports in Queensland and also nationwide. And there is definitely a recognition from our end that there was risk assessment processes and decisions in regards to lethality indicators, as well as sort of children and young people starting to exhibit perpetrating behaviours. So recognising that as an area of intervention in its own right, and children as victims of domestic and family violence as to be considered in their own right. And then research on fathering suggested that, there is definitely more work to be done on kind of engaging fathers or perpetrators. I don't want to equate that necessarily. So say perpetrators, holding them accountable and engaging them actively in the intervention is part of that recommendation. Recommendation 5 then was about promoting the safety of infants and unborn children, again, sort of with relation to preventable death, but also then sort of looking at sudden unexpected death in infants and what can be done to promote the safety in that space in terms of collaboration between agencies and so on. And recommendation 6 was about promoting the safety of children with a disability. So talking about hang on, I've just got to scroll down here in my notes for a second. So I guess, with the disability, definitely was around vulnerable families and sort of helping them to navigate, the NDIS. And I would put my hand up wholeheartedly in saying that when I first saw one of those access request forms and the paperwork that is involved to actually get a child into the NDIS when it was first rolled out, I felt overwhelmed by it, and I had received training for professionals to try and deal with that. And a lot has been done since the rollout of the NDIS in Queensland to make that process a whole lot easier. At the same time, though, I think that is a really important space to sort of help with that engagement and sort of take some of that scariness away for families of children with a disability who have other challenges in their life and are overburdened with sort of lots of things that they need to be taken care of. So that was that 6th recommendation. Which leads me to the research reports that have been commissioned since 2020 directly by the board. So we've got 3 reports that have been commissioned and published, and then there's one that is currently in the process of procurement. And the 3 that were published, so there's one on preventing youth suicide, published in 2021. We have one on sudden unexpected death in infancy among vulnerable families in Queensland, also 2021. And then more recently was the domestic and family violence report reviewing the child protection system's response to violence within families, which was published at the end of last year. And they're all available on the Child Death Review Board's website, which I have listed at the end of this presentation in the further reading slide as well. And then the one that we are talking about and talking a lot about, actually, it's been sort of taking over my life for a little while there, is the methamphetamine use by parents of children under 3 years. And that's directly linked to some pretty strong findings that substance use was one of the identified factors with sort of like a really pointy end around the methamphetamine use by parents of children under 3. So quite a high number of cases that have come before the board where that was identified as a factor. And then sort of coupled with the recognition that sort of in the Queensland context, we haven't really got as much in terms of the research, and there's a lot of unknown factors, which then led the board to commission this research project to have a bit of a comprehensive report around guidance for practitioners moving forward, and what that threshold, at what point sort of, future risk of harm turns into immediate harm, especially if the children are so young and vulnerable. Violence within families. So I just wanted to kind of give a little bit of contextual information around that in a bit more detail, because it is sort of one of those things that we are collaborating strongly about. So the Domestic and Family Violence Review Board, where cases are reviewed, where people have died as a result of domestic and family violence here in Queensland. They are one of our key partners, and we are into the future. We're really looking to find ways to collaborate and share our findings in a meaningful way. And because it's sort of one that gets talked about so much, and it's the last report that we sort of provided. So we've got a really strong focus on not just identifying, I suppose, the problem and talking about what is contributing to the problem and what holds the problem firmly in place. It's also about how do we respond and how do we build capacity among frontline practitioners and the system as a whole. So some of the findings will then sort of directly feed into recommendations for building better I suppose, better responses and supporting frontline staff to engage meaningfully with families around domestic and family violence. So the visual case examples, I left them right to the end, but I did want to show, so we've got some de-identified timelines, which I will be talking to in a moment, but I also wanted to show sort of like some of the sort of compounding challenges, or when we've got sort of complex challenges in our level 3 reports, that's what it kind of looks like across the board. So we would, with our issues classification register, which has sort of like items around what some of the common themes and identified issues are, will help us sort of like navigate, I suppose, and visualize the compounding challenges that are experienced by children, young people and their families in the 12 months prior to their deaths. And you can see that there's sort of like across the board in terms of the systems representation and what is going on for family, that there are some very complex challenges at work that we then sort of try and highlight in our reviews. So almost all had child protection histories. They were not attending school. Many of them engaged in illicit substance use, and that can start from as early as 8 or 9 years old. There was an expression of suicidal ideation or poor mental health kind of recognized, and then often there are trajectories of trauma and adverse childhood experiences early in life as well. Yeah. So moving on to the timelines. So this is kind of what they look like. Obviously, these are de-identified, but it just does provide sort of like a bit of a trajectory around, I suppose, the review period that we look at. And then there's like information around, where the systems sort of engaged and had some overarching engagement. At times, sometimes communication between systems indicates that they know that another agency was involved at the same time, and at times that is not always the case. So there might be child safety involvement, and for whatever reason, some concerns say that were noticed in the education space, for example, sort of go unnoticed, or the systems don't know about each other's concerns, and those timelines really indicate and highlight what that might look like for a child or young person. So with this particular young person, they died at age 17. Family was known to child safety, in particular due to domestic and family violence perpetrated by several of the mother's partners. There was also then sibling violence, sort of strongly indicating again that at times when children and young people are exposed to domestically violent behaviours in the home, at times they will start to exhibit these behaviours in their own responses to stress and adversity. There's suicidal behaviours, there's mental illness, substance use, risk of homelessness, and poor supervision of the children. So probably quite a bit of neglect going on then as well. So this young person was admitted to Child and Youth Mental Health Services as an inpatient unit under treatment authority. And so the icons show that when that was happening. If you look at the green horizontal line there at the end of the timeline, that was when there was an inpatient treatment authority going on. Ongoing suicidal ideation and expressions of intent, including expressions consistent with means of death, and multiple non-fatal suicide incidents in the year prior to the death. Yeah. I'll let you take that in for a minute. I've got another timeline that kind of, so when you kind of look at that sort of towards the end of life, there you can see just by the sheer clustering of the icons how much system intervention was actually provided, and that there was a lot going on in that child's life, including Ryan's rule activated 3 times. And then overall here you've got, the overlay of the court space and also the child safety interventions that were implemented over the top of the very strong concerns for the child's mental health and suicidal ideation and attempts. Okay, so this next one, even busier. I always kind of find it really amazing, like how much these timelines can kind of illustrate just on the one page and what is going on there, and how that story of the last 12 months of a young person's life is sort of visualized, for people to see how much they had on their plate and how much was going on for them. So this young person died at the age of 13, was subject to an interim custody order and placed in residential care through child safety, had an extensive background of childhood trauma and neglect, disengaged from education, There were some high-risk behaviours, including substance misuse, criminal offending, aggressive and destructive behaviours, a history of suicidal ideation, and then there was also a suspected intellectual impairment. And when we say that, that usually means that we can't tell for sure, and that at times things got in the way of properly and formally assessing whether that was happening. And then as a result of that, there was probably limited opportunity for the NDIS to provide extra, like the support that that young person probably needed. Yeah, so there's quite a bit going on for them. So the horizontal purple circle displays the Queensland Health response, particularly context relating to sibling suicidal behaviours and planning around Navigate Your Health, which is sort of the child safety health response that children and young people in care can access in some areas in Queensland. Oh, goodness, sorry. And then the light blue items at the bottom is what we receive from child safety. The green depicts education's information, and then there's orange is police responses, purple and red alert signs are suicidal attempts and ideation and illicit substance use, and this young person was only 13 at the time. Now the vertical purple line, I was a little bit trigger happy, sorry about that, popped up too early, but it shows a time when the agencies came together for a suspected child abuse and neglect meeting, so the SCAN meeting, as part of missing persons protocol. So that's a multi-agency group which meets to share information about a child and coordinate the actions to respond to what the child needs at the time. And so the key stakeholders at a SCAN meeting are Child Safety, Queensland Police Service, Department of Education and Queensland Health. However, they can also invite guests and representatives of other services if it is relevant to the intervention moving forward. So for example, representatives of a mental health service or a domestic and family domestic violence service can be asked to come along and provide advice, or a counselling therapeutic service for trauma is one that quite commonly would provide feedback around how the child or young person is going, and that can be tertiary or secondary or even primary in terms of who gets invited there. At this time, with the vertical line here, the child had recently had their placement closed, so residential placement that was closed at the age of 13 because they hadn't, so they identified that they hadn't spent enough time at the residential. So often this happens when children and young people decide to self-place or take matters into their own hands and not stay where they're allocated a placement for whatever reason, sometimes scary. There are some things that sort of make it really hard for them to stay. Sometimes they're worried about their own family and they go back to check on them. And here in this instance, they were safe placing with mum and living in abandoned houses, suspended from school, at their first youth justice court appearance, several recent incidents of suicidal ideation and attempts. So those pressure points then really kind of coming to a head, and was referred to Navigate Your Health. However, that was closed not long after the child was referred because they didn't engage. That was the reason provided. Yeah, and this SCAN meeting occurred at a critical point in time because, obviously they went missing, and the protocol is that children who go missing and have to be reported to QPS as missing children, that they be reviewed at a SCAN meeting. So the reflection was around intervention at the tipping point for children with trauma-related behaviours before they escalate into child safety or youth justice systems, and the models that would allow the system to stabilise children while there's assessment of support needs and connecting them up into services. And you can see like how much the system actually attempted to intervene just by the sheer busyness of this timeline, and that at times adverse outcomes still cannot be prevented, unfortunately. So that's really all I had prepared for you all, except obviously the further information and the reading that can be accessed mostly through the website. And if you wanted to contact us, there's the contact details also, if you wanted to shoot us an email or have further questions. Thank you so much.
Thank you, Andrea. Those timelines are really quite sobering. So thank you very much for your presentation today. That brings us to the question and answer session. So happy to kick off the questions for the speakers. As I say, Kirsten's unable to attend, so we're happy to pass on any questions specifically for Kirsten. But if I kind of kick off, Andrea, kind of starting with you, given that you've just literally obviously that the board has been in existence for years. Do you have any kind of overriding insights of what are the main systemic issues that seem to be reoccurring in certain cases known to child safety?
Yeah, look, that's a really good question, Jamie, and it's definitely and something we talk about, I guess, all the time, is around the risk assessment, and of course, when we're kind of looking at the last 12 months leading up to a child or a young person's death, we would look at how risk is being assessed and what could be done to sort of strengthen the level of safety that they have experienced or moving forward to prevent other children and young people from experiencing a similar fate. So risk assessment is definitely something we talk about all the time. Then we've got some really strong and rich discussions coming up also, which are very timely around youth justice intervention, and in particular what sort of happens in Queensland youth detention centres. So that's one that's sort of up and rising, I guess, with the research project that's been commissioned around the substance misuse, especially when children are really young, and how that sort of impacts not just I suppose their parents in general, but the whole the impact on the child, and how that sort of connects up to assessing risk and sort of that determination between what is an immediate indicator of risk and what is risk of future harm, and at what time does the scale tip and how quickly does it tip. When we're sort of looking at what could be fine one day in the context of lots of challenges such as substance misuse, domestic and family violence, and mental health concerns, say, for example, if they're all present within the same family unit, what could be fine 1 minute could be really dangerous 10 minutes later if there's not an adequate safety net sort of implemented there. So they are some of the discussions that we've been having. There's also across the board, if there's sort of limited visibility. So we talk a lot about the invisible child, children that are invisible to systems. So if you've got compounding challenges of, say, housing instability, disengagement from school, or if the children are in out-of-home care, frequent placement change, not having a placement, and therefore sort of slipping through the cracks of the system. Another one would be what Mandy was talking about, the cultural connection of children and young people, and really being disengaged from their culture, community and country. Those are some of the things that we do see and that we do talk about a lot. Are there any other ones, Jamie?
That's a fair chunk already, Andrea. So thank you for that answer. Kind of linking from that answer around risk assessment, kind of Beck and Paula, do you think that this work will bring about a bit of change around retraining that may be needed for clinicians as well as coders and some of the kind of pathologists and so on around, identifying and then recording sepsis?
Yes, I do. I think in the end, there's a big piece of work being done by the George Institute, in particular, looking at that across the country. That there is a change coming from a coding point of view. It's still going to be difficult, though.
Yeah, it's a bit of a long road ahead, you think, Paula?
Yeah, I do.
But it'll be important in terms of your timeframes for your research and some of those kind of findings. Do you have any views on when that may be at a public-facing stage?
In terms of the coding, I mean, that's kind of out of my hands, unless Beck's got something else to add. But in terms of public facing, I mean, there are so many strings to the bow of improving outcomes from sepsis. This is one of them because it enables us to track it better. There are any number of similar getting at clinical data within the hospital system, automatic recognition. There's any number of different prongs to this approach that we're coming. So I can't tell you when, but it's coming.
And just in terms of our work around this, we're probably a couple of months, I guess, away from having more findings and getting those out into the public domain.
Okay. Mandy, in relation to your work, given many of our participants today will be kind of maintain child death registers and we gather and capture information, do you have any advice for us in terms of what data is important to capture in relation to First Nations, or do you think it'll always be a need for data linkage around that cultural connectedness, or do you think there's something we should be capturing at source now?
I think that's definitely, it's a bit of a yes and, isn't it? That there's a lot of information of the key risk factors in suicide that are obviously part of the puzzle, but there's, for First Nations people, particularly with suicide, it tells a much less share of the story. The recent attempts and all the kind of what we call classic indicators are less predictive as such for First Nations community, particularly young people in suicide. So the need to also be collecting other information on significant events in communities that I think, particularly the findings on discrimination. So that is kind of coming out, and in the clinical partners we work with, that the significant events are like police violence or altercations with services, or the significant sorry business and exposure to other suicides and potential clustering effects within communities that are at times not as simple as in communities with discrete communities, but the family networks that might expand a number of sites in Southeast Queensland. So in terms of the information we're looking at, I do think for suicide, there is a lot else for First Nations young people we need to be better at incorporating in how we help make decisions and support them in turn on the back of those decisions.
Thank you, Mandy. And one of the questions coming through, which I think all of you could kind of contribute to, is just about what those information sharing kind of mechanisms there are in Queensland. Do you all experience barriers to some of that around, or do you rely on legislation to allow that to move freely? Andrea, do you want to speak to that first?
Can you repeat the question? Sorry, I'm not sure I understand.
Sorry, just about information sharing and has that been a barrier for us?
Oh, yes. Oh, sorry. Yes, of course it has. I mean, there's definitely a tricky space around trying to negotiate and making sure that the systems kind of know what the other system is doing, especially when it's coupled with high workloads, and sort of like a reactive response rather than proactively planning things into the future. So that's what gets noticed in those reviews quite a lot. And then it's never about, say, individual failings, really. That's, you know, we're just sort of more interested in like how could the systems improve their communication mechanisms and their information sharing mechanisms to make that more accessible, I guess,